The next lecture will be Dr. Fronzo about diabetic nephropathy.
Okay, we found it, we're ready to go. So I'm going to put my nephrology hat on today, and we're going to talk about diabetic nephropathy. And this complication is the leading cause of end-stage renal disease in the United States and Europe. And in the US, and this is actually true of Europe as well, about half of all patients entering into dialysis units have diabetes as the etiology of their disease. It's a very, very expensive disease to treat. And in the United States, it takes up 1/4 of the care of the expense of patients on Medicare. And people who end up on dialysis have a markedly increased incidence of cardiovascular complications. So who is affected? If you look at type 1 diabetics, about 30 to 40% of all type 1s are affected. But for type 2 diabetes, it's much, much more variable. So in the Western world, and I think this is probably here as well, Caucasians have the lowest incidence of diabetic nephropathy. We sort of kind of lucky. Blacks, African Americans, the incidence goes up. It's about 10 to 15%. Mexican Americans, even higher. And American Indians have the highest incidence. So what is this telling us? It's telling us there's a very strong genetic background upon which poor glycemic control is now bringing out this particular complication. And although we tend to focus on the glomerulus, diabetic nephropathy affects all parts of the kidney. So the classic finding is this increase in PAS positive staining material. This is the best predictor and correlate of who's going to develop diabetic nephropathy. As this material starts to coalesce, you get these characteristics, Kimmel-Wilson nodules. There's no other disease that looks like this other than amyloid, but you can stain for it. We also know that the small arterioles are involved in the kidney, and this plays a major role in development of hypertension. And there's also tubular basement membrane thickening, and I'm not going to get into the acid-base disturbances, but you very commonly get problems with hydrogen ion excretion and potassium excretion, although when we're taking care of the patients, we tend to focus on the proteinuria and the renal disease. So I drew this slide some 30 years ago, and I think it actually still is the most appropriate description of what goes on in people with diabetic nephropathy. So at the time you make the diagnosis of diabetes here at time 0, there are no clinical or laboratory clues that's going to tell you who's going to develop diabetic nephropathy and who is not. So you look at the glomerular filtration rate, it's 150, looks normal, creatinine looks normal. But in fact, these numbers are not normal. So there's a very famous study that came out of Denmark where people who had a very high likelihood of developing diabetes had a kidney biopsy before they developed diabetic nephropathy. And in fact, if you look at these people before they develop diabetic nephropathy or develop diabetes, you can see that they are hyperfiltrate. They have an elevated GFR, they have lower creatinines, lower BUNs. And this hyperfiltration is due to an increase in intraglomerular pressure, and it's that increase in intraglomerular pressure which is playing an important role in the pathophysiology of the disease. Now, if you were to follow this individual, because this study actually was done, what you see is, again, there's no change in the function, but you already now see within 3 years you start to see the histologic changes. So this is not something that we can do in clinical practice. You can't just sequentially biopsy someone to see if they're going to be at risk. So it would be nice if we had some biomarkers that told us who is going to develop diabetic nephropathy early on, and unfortunately, those biomarkers are not available. Now, as you follow this individual, there's a very long silent period. It's on average about 15 years. And when, at this time, you now start to see the patient, this patient becomes a problem, because now they have proteinuria. And there are no studies that I'm aware of that show that once you have macroproteinuria, that good glycemic control is going to slow down this process. You may be able to slow down the retinopathy and the neuropathy, but once you start to get significant macroproteinuria, this person is in trouble. And then within a period of 4 to 5 years, you get a halving of your GFR, and then within another 3 to 4 years, these people are at end-stage renal disease. Now, the comprehensive treatment of people with diabetes who have chronic kidney disease is threefold. Number one, we want to stop the progression of the renal disease. We don't want them ending up on dialysis or getting a transplant. The second problem is these people are at astronomical risk for cardiovascular complications, and drugs like statins actually work very, very poorly in this group. And then thirdly, we very commonly see eye problems. In fact, we call this the renal retinal syndrome. And I would say, if you don't look in the eye grounds and you don't see evidence of diabetic retinopathy, this person does not have diabetic nephropathy. You ought to be thinking of something else. So we don't want the other complications to progress. Even though intensive glycemic control may not have a big impact on slowing the demise in renal function, we can't let the person go blind and develop peripheral neuropathy. So what can we do in people with established diabetic nephropathy? These are people who have proteinuria or they have a decrease in the GFR. Well, first on the list is hypertension. So hypertension is the single most important abnormality. It, when treated, will slow the natural history of the disease. And of course, we all know that the ACEs and the ARBs are the drug of choice. But I want to say that more important than the ACE and the ARB effect is simply lowering the blood pressure. Probably 80% of the benefit from the ACEs and the ARBs comes from lowering the blood pressure and not from the angiotensin II blockade whatsoever. And this was very nicely pointed out by Hans Henrik Parving many, many years ago, when he's following people now, and he sees the GFR is dropping progressively. And at this point, 20 months into the course, he says, I need to intervene. So what did he intervene? Diuretics. Which one? Mercurial diuretics. These are injectables. You have to be my age to have used these drugs. They had guanethidine. I mean, no one would use that drug today. Eldamet. These are barbaric medications. But look what happened. He markedly attenuated this decline in GFR. So from the standpoint of what we can do, controlling immaculate control of the blood pressure is critically important. Now, there's a lot of debate as to what should be the maximum blood pressure. Some people say 140 over 90 is okay. I would say the more recent data suggests that we should be down to 120 to 130 over 80. What else can we do? Well, in addition to lowering the hypertension, there are some medications that have a benefit above and beyond lowering the blood pressure. This is the ACE and the ARBs, and these really should be the drugs of choice in our patients who have diabetic nephropathy. So how do these drugs work? So there's a small blood vessel that enters into the kidney. It arborizes the glomerular capillary tuft, and then they coalesce, comes out the afferent arteriole. Within each nephron segment, there is increased sensitivity to angiotensin II, vasoconstriction of the downstream vessel, increases the pressure within the glomerulus, so you have a hyperfiltering, and also angiotensin II makes your kidney growth larger, so you have a mega kidney that's hyperfiltering. Looks good initially. On a long-term basis, this damages the kidney. Intensified glycemic control. So many years ago, when I was a faculty member at Yale, with Bob Sherwin, we asked the question, can good glycemic control prevent the development of diabetic nephropathy? And if it couldn't, could we at least slow the development? And so we had a very large grant to look at this from Mr. Kroc, from the Kroc Foundation. Does anybody know who Mr. Kroc is? Mr. Kroc owns McDonald's. And Mr. Kroc had diabetes, he had Parkinson's, and arthritis, and he funded research in those areas. So we carried out this study, and actually at Yale, this was the first insulin pump study. And we took people with type 1 diabetes, and you put them on insulin pump therapy, and you can see we actually normalized the fasting glucose concentration, and here we're using the total glycosylated hemoglobin. So the value looks a little bit high compared to what we do now. And you can see it came down into the normal range. So this actually was a pretty good job of getting the glucose under control. And what happened in these patients? So these people started with a lot of protein in the urine, almost 3 grams. Creatinine is about 1.2. Here's the creatinine clearance, a little bit low. Within 6 months, there was a nice decrease in proteinuria, no change in renal function. When we saw these results, we wrote this paper in one night. We sent it to the Lancet, and this paper was in press in 2 weeks. It still holds the world's track record for the fastest publication of any paper in the Lancet. Well, the Lancet has another name. It's called the Journal of Irreproducible Results. So this result was unfortunately in some ways producible, in other ways irreproducible. Because what happened? As this study went on, what you can see here is the proteinuria came back, the creatinine went up, and the creatinine clearance went down. And there is a level of macroproteinuria that's somewhere about 300 to 500 milligrams of albumin in the urine. When you get to that level, intensifying the glycemic control has very little to no effect on preventing the progression of diabetic nephropathy. Another reason for starting to treat this disease early to prevent this complication and make sure the glucose doesn't rise. Low protein diets actually were shown to be effective in the old days, but when the big NIH trial was carried out and people were on ACEs and ARBs, and then you put people on a low protein diet, the low protein diet had no benefit above and beyond treating the people with the ACE and the ARB. So now all we say is the people should not really be on a high protein diet. And then most recently we have the SGLT2 inhibitors. I talked a little bit about this yesterday, but the SGLT2 inhibitors work in a different way than the ACEs and the ARBs. So as part of the renal compensatory response, there is afferent arterial vasodilation in an attempt to more blood, more GFR, but unfortunately that also increases the intraglomerular pressure. The SGLT2 inhibitors vasoconstrict, okay, the afferent arterial, they decrease the intraglomerular pressure, and in doing so, they preserve renal function. That's what we are all told, and this is true. But as I'm going to show you, there are many other mechanisms that are involved here. And all of the studies I'm going to show you that showed the benefit of the SGLT2 inhibitors were carried out in people who are on background therapy with an ACE or an ARB. So these drugs can be used together to maximize the benefit in terms of renal protection. So this is the standard sort of theory behind how the ACEs and the ARBs work. So when you're hyperglycemic, you filter more glucose, and because you filter more glucose and sodium are reabsorbed in the proximal tubule. That means less sodium is going to get down to the juxtaglomerular apparatus. It looks like it's being underperfused, and so what it does, it sends a signal to the afferent arterial to vasodilate, and to the efferent vessel to vasoconstrict. And so we can intervene with ACEs and ARBs. They dilate the efferent vessel and the SGLT2 inhibitors to constrict. And this actually has been shown, and it's real. It's been shown in people. as well. And now when we take this to practice, the very first data came out from the infrared outcome trial. And they had a secondary composite renal endpoint, which is shown here in orange, was decreased by 39%. And this was, of course, highly statistically significant, p less than 0.001. Now, what about the individual components? The first one in yellow is doubling of the serum creatinine with a GFR less than 40. So if your GFR is less than 40, your creatinine is already 2. If I double your creatinine, it goes to 4, you're ready for dialysis, okay? And this was decreased by 44%. Macroalbuminuria, which is blue, is decreased by 38%. And then end-stage renal disease, meaning you end up on dialysis or having to get a kidney transplant, is decreased by almost 50%. Each one of these individual components was statistically significant, incredibly impressive. And then the next two drugs that came were canagliflozin in the CANVAS study, and then dapagliflozin in the DECLARE study. And it doesn't make any difference whether you look at people with established cardiovascular disease or people who haven't had an MI and have multiple risk factors. If you look at this composite endpoint, it's decreased in all of these studies. And now, most recently, we've had the CREDENCE study. Now the primary endpoint is end-stage renal disease. And what you can see in the primary endpoint in this study is a dramatic effect as well. So these people, of course, had to be poorly controlled. They had to have either a low GFR, or if they had a normal GFR, or near normal, they had to have macroproteinuria. And there were two endpoints, either renal or cardiovascular. And the renal endpoint was exactly what I showed you before. And this study was stopped early because the results were so impressive. And there was a 30% decrease hazard ratio of 0.70 of the combined endpoint, which was cardiovascular and renal disease. So let's now look at each of the individual endpoints. So this is the composite cardiovascular and renal endpoint factored by what the GFR is. So as I told you, there was a hazard ratio of 0.7, a 30% reduction when you look at the entire group. But if we break it down, you had a GFR 30 to 45, 45 to 60, 60 to 90. Every one of these is statistically significantly decreased. So it doesn't make any difference what your starting GFR is, that composite endpoint is reduced. But what we really want to know, what is the specific effect on the kidney endpoint? And the kidney endpoint is the composite endpoint, which I told you about. And again, whether you have a low GFR, intermediate, or relatively normal GFR, there's enormous benefit from the SGLT2 inhibitors. Another reason why I like these drugs as first-line therapy. But as I showed you yesterday, there are multiple causes for the diabetic nephropathy. And this has important implications in terms of therapy. So as we go around, okay, the derangement in glomerular tubular feedback is what we just discussed. But in fact, the very first abnormality in every animal model is tubular hypertrophy. And if you block the tubular hypertrophy, even before there's any glomerular damage, you completely block the glomerular damage. So this says that growth factors are playing a very important role here. We also know that the kidney becomes hypoxemic. And when it becomes hypoxemic, you generate a number of factors that are initiated by HIF, hypoxia-inducible factor, and this leads to release of inflammatory and sclerosing factors that cause glomerular fibrosis. The podocyte in the kidney is the endothelial barrier, and just as we get endothelial dysfunction in the whole body, we get endothelial dysfunction in the podocyte. Albumin leaks into the lumen, and albumin is particularly toxic. Now, even before we look within the kidney, what starts the disease is hyperglycemia. So if you're not hyperglycemic, you don't get diabetic nephropathy. We talked about the very important role of hypertension, and we now know that there's an obesity lipotoxic effect, which I'm not going to go into, but just as you deposit fat in your arteries, in your muscle, and in your liver, you also deposit fat in the kidney where it incites an inflammatory sclerotic process. And then, of course, the genetic background is very important. And if we look at the SGLT2 inhibitors, they correct 6 of these 8 problems. So people want to focus on the tuberoglomerular feedback aspect of things, but I think we need to broaden our perspective and then look at the whole picture. Now, what about GLP-1 receptor agonist in diabetic nephropathy? This is a recent study with dulaglutide, and there is, again, suggestive evidence that the GLP-1 receptor agonist will also give you cardiovascular protection. So the hazard ratio here is 0.85, but it's largely driven by the decrease in development of macroalbuminuria. I'm a little bit skeptical, but these drugs are going to be as good as the SGLT2 inhibitors, but nonetheless, there is a lot of interest in this class of drugs. And I'm going to end with this last concept of microalbuminuria. What is it, and why is it important? And you've heard a little bit more about this yesterday. So normal albumin excretion is less than 10 milligrams per day. So to make sure that we're high enough above the normal range, people have said we're going to choose 30 milligrams as sort of the lower endpoint. And then when you transition to macroalbuminuria, that's at 300 milligrams. So microalbuminuria is this range, it's 30 to 300. So when does the microalbuminuria occur? The microalbuminuria occurs, if you come back to this diagram that I showed you, that from the time of onset to the onset of macroproteinuria, it's about 15 years. The microalbuminuria occurs about 10 years earlier. So people raise the question, 5 years earlier. If I can back up 5 years in time, and if I now treat these people, can I make a difference? And so first, I'm going to show you some data with type 1 diabetes from the DCCT trial, and then I'll give you a summary of what happened in type 2s. So in the diabetes control and complications trial, this is intensive insulin therapy in type 1s. When people got the standard therapy, their A1C didn't change, stayed at 9. With intensive insulin therapy, it dropped to 7. And remember, this is the first study in type 1s that showed that intensified glycemic control decreased the complications. So what happened in this study? So let's say you had no microalbuminuria, and you want to see who developed microalbuminuria. So the placebo group here in the bottom, there was a 58% reduction in the development of microalbuminuria in people who had no microalbuminuria. Now what if you had already had microalbuminuria? What happened in terms of progression of macroalbuminuria? Here you can see there was a 43% reduction. So intensive glycemic control, actually if you start early enough at the microalbuminuric stage, will work. Now what about type 2s? So in type 2s, I might say that microalbuminuria is actually not a great risk factor for diabetic nephropathy. It's a great risk factor for cardiovascular disease. Nonetheless, it is a risk factor, and if you intervene with intensive glycemic control, and I've listed some of the studies up here, you can show that there's a significant decrease in the progression. There are also very good data if you intervene with ACEs and ARBs in the microalbuminuric stage, you can prevent the progression. So I would say now, in people who are at risk, we need to be following the microalbumin excretion. Once we see the development of microalbuminuria, these people should probably be put on an ACE and or ARB plus an SGLT2 inhibitor, and you really need to tighten up the glycemic control in these patients. There are a lot of new agents that are being looked at. Some of them look actually quite promising, but they're still 3 years off. So basically, we're left with controlling the hypertension, controlling the dyslipidemia, making sure we have good, tight glycemic control. And in my opinion, these people should be on dual therapy with an ACE and or ARB and an SGLT2 inhibitor. I think we can stop here. Too late for questions, or you want to have a few?
No, questions will be after break.
Yeah.
Thanks a lot, Dr. DeFronzo.